So I would like to introduce Dr. Ali Prebtani. Dr. Prebtani is an internist and endocrinologist at McMaster University and a full professor of medicine with the Division of Endocrinology and Metabolism, Department of Medicine. Dr. Prebtani is currently on the expert committee for the Diabetes Canada Clinical Practice Guidelines and Task Force for the tools implemented for hypertension. When Dr. Prebtani's not busy presenting presentations locally, nationally, and internationally, he enjoys camping, traveling, and dancing, and apparently hanging out with his children. Welcome, Dr. Prebtani, and he's going to do his presentation for us on diabetes 2, which I felt was really important, and acromegaly.
Thank you, Deanna, and the organizing committee for inviting me today. I just wanted to really apologize that I got here late. I was on call, and I actually went to the hospital at 6 in the morning so I can make it. But hey, you know what? I have no control over people's hearts and kidneys and lungs, and unfortunately we had some cases that were very sick today, but I did jet over. And then I got here and the entrance was closed. So I had to go all the way around, and then finally I made it. But I'm glad I'm here, and it looks like a wonderful conference. And the bar is set really high because Dr. Izzat was my mentor, and Dr. Asa was my mentor, and Dr. Imran was my mentor. So there's a really high bar that has been set, and hopefully I can at least do some justice. And I'm open to questions and feedback. I'm always learning. It's humbling that the more I know, the less I know. That's what it seems like every day of my life. And I'm always learning from my peers, my colleagues, and my residents, and children and young people. I think we learn from everyone. So I won't be philosophical anymore. I'll start off with some discussion of what I was asked to speak about today. So how do I advance here? Okay. So these are my disclosures. So type 2 diabetes is very, very common, and I'm going to somehow relate it to acromegaly, which is the theme of the discussion today and tomorrow. I know most of the crowd here is patients and families, and there is a subset of attendants who are physicians and allied health professionals. So I've tried to make it more geared towards the lay public, which is probably more relevant because I always learn from you also. And I know this is a very high level crowd, so I tried not to make it too simple, yet not too scientific either. I tried to keep it balanced, and I'd be interested in getting your feedback. So type 2 diabetes is actually very common. We're talking that it actually runs in the water these days, and I'm sure each and every one of you know someone who has diabetes or multiple people. In fact, as you get less younger, and I never say old because no one's old, you're less younger as time goes on, that the risk of diabetes goes higher and higher, especially because we sit a lot these days and don't run enough and don't have the lifestyle that we did many, many years ago. So to simplify, type 2 diabetes is a condition where either or a combination whether you're not making enough insulin, or you're making enough, or maybe even too much, and the body is just not able to use it properly. So what happens? You get high blood sugars. But that's not the end of it. The high blood sugars on an ongoing basis will cause troubles to many, many organs, including the eyes, the kidneys, and the nerves, but most importantly, the vascular system, which is all the big blood vessels in the body, in particular the heart, the brain, and the arteries in your legs, where you can get poor blood flow, so you get problems when you walk and pain and things like that. It's very complicated. The control of glucose is actually just not about the pancreas. It's the muscle, it's the fat, it's the brain. Now we even know it's the gut, and now it's even the kidneys. There's drugs that we're using on the kidneys to get better control of type 2 diabetes mellitus. So at the end of the day, our goal is to stay active, and a lot of good news that we have right now is that we can prevent the complications of diabetes by controlling sugar and by doing other things also, not smoking and controlling blood pressure, and I'll go into all of that because that's all important. And that's why I call this the ABCs of diabetes. It's more than the ABCs. It actually goes up to D, E, F, G, and you can go on and on. So how common is diabetes? Very common. Like I said, the less younger you get, the more common it gets. But if you looked at everyone in Canada, it's roughly about up to 10% of the population has type 2 diabetes. A small population has type 1. Then we have another category, which is even less common. So it's a major public health issue, and it's costing our system a lot of money. You know, acromegaly is very, very rare. Diabetes is at the extreme. It's very, very common. And it's more common in certain ethnic groups, South Asians, Hispanics, the indigenous population, just because of the genetic makeup and other risk factors also, such as a sedentary lifestyle and the food and so on. So again, this is not an uncommon condition. It's very, very common, and the good news is we can do something about it. So what are the risk factors? Everyone in Canada has a risk factor for diabetes just because of our lifestyle, unfortunately, that has gone quite extreme. Sedentary lifestyle, genetics is a big risk factor. As you get older or less younger, after the age of 40, your risk of diabetes goes up also. Schizophrenia has an association with type 2 diabetes. Family history is obviously big, and other conditions that are associated with diabetes puts you at higher risk for diabetes. High blood pressure, also known as hypertension, cholesterol issues, certain types of cholesterol issues, especially if you have high triglycerides and low HDL, which is one of the good cholesterols, that if it's low, it puts you also at high risk for diabetes. And if you've also had increasing weight, or we call obesity, you're also at higher risk for diabetes. But interestingly, everyone who's obese won't get diabetes. There are some people that fascinate me that are obese by the medical term, but they never get diabetes. So there must be some kind of genetic protection there, which we still haven't learned a lot about. So it's always humbling. There are things we still don't know, and we're still trying to learn more and more. And one day we will find out why that person who has the same weight as that person, they're different. One gets diabetes, the other one doesn't. And this always fascinates me. Another one is if you've had pregnancy and diabetes, then your later onset risk of diabetes is also higher. So there's many, many risk factors. Our goal is to control the ones you can control, but some of them you don't have control over. You can't control your parents' genetic condition, unfortunately. Maybe in 10 years you can. We can do all kinds of things, but not in 2019 or almost 2020. So this is just a nice graph showing that the more heavier you get, your risk of diabetes goes up. We always focus in on weight, but it's not only weight. In fact, the risk of diabetes is much higher correlated with the apple shape. It's a term used that the more weight you have around your belly has a higher risk for diabetes compared to more around your hips. So if you had to pick a fruit, be a pear rather than an apple, right? I know this is how we always learn these things, right? But again, this has been shown quite well in many, many studies that the waist circumference puts you at much higher risk of diabetes than the body mass index itself, which is the weight over the height. There's a calculation you can do that you may have heard of. So how do you make the diagnosis of diabetes? Most people in Canada, or the Western world at least, don't have symptoms with diabetes until they get complications. That's why it's important to get screened if you have risk factors. So often we call it asymptomatic. But how do you make the diagnosis? There's several ways you can do it. We can do a test called a hemoglobin A1C, who's heard of a hemoglobin A1C? Most people, in fact, know their hemoglobin A1C. It's the glucose or the sugar that's bound to the red blood cell. It gives you a 3-month average of your sugar, the hemoglobin A1C. Just in acromegaly, we have an IGF-1 level. There's a similar thing in diabetes called the A1C. It's average of your overall control, of your glucose control, just like IGF is a growth hormone average over time. You can also do a test called a 75 glucose tolerance test, where you drink this horrible tasting thing that many pregnant women do, and you can check a sugar 2 hours after that, and if it's very high, then you have a diagnosis of diabetes. You can also have a fasting glucose that's above 7, can also make the diagnosis of diabetes. And if you have symptoms, or even without symptoms, but if you have repeated measurements of a sugar above 11.1, then you can also make the diagnosis of diabetes. So there's many ways to make it. The important thing is you want at least a couple of tests before you actually commit someone to diagnosis of diabetes. So I've already talked about this briefly. Most common cause of diabetes is type 2, more than 90%. A smaller proportion is type 1. Then even a smaller proportion is other. And what are the others? What are we here for today? So acromegaly is one of the other causes of diabetes. Cushing syndrome is another cause of diabetes. There are also some genetic causes of diabetes, MODY and so on. It's not important to know these things, but the broad thing to remember is type 2 diabetes is the most common cause of diabetes, followed by these other conditions. Sure, good question. Okay, so there are some medications that can also cause diabetes. There's drugs called prednisone, which can cause what we call exogenous Cushing's, and that can also predispose you to diabetes. There's even certain medications we're using for schizophrenia, or also in the psychiatric world, that can predispose you to the risk of diabetes. Even some of the drugs we use in acromegaly, interestingly enough, some people may worsen their diabetes, or it can unmask diabetes. But not everyone. It's always hard to predict. But drugs like sandostatin or somatulin, which we use to control your IGF and maybe even the tumor, can also make some people at risk for diabetes and unmask diabetes or worsen their diabetes. So when we see a patient, we use personalized medicine. We look at their tumor, we look at the patient, we look at the brain, the imaging in the pituitary, and we also look at the risk of diabetes. And based on all those conditions, all those factors, we pump out the best therapy for that patient sitting in front of us. So, all the patients are unique. They're important people. So we just don't use a cookbook approach where everyone should be going on to that drug or that surgery or that radiation. We have to look at the entire patient before making the right decision for that patient so they get the best effect and the least side effects. Does that answer your question? Or did you want to?
No, well, I shouldn't say no, so, but let's say you are in San Jose.
Yeah.
And you are tested for diabetes.
Okay.
Is it a good mask?
What I mean by that is that unmasked. Sorry, I meant unmasked. So someone who's at very high risk for diabetes, in some people, maybe these drugs, not in all, may actually make the sugar levels go high. Not in everyone. It's really hard to predict all the time, but if you see that, it may be the medication or it may be the condition of acromegaly itself. So that's when you need to speak to your healthcare provider or your endocrinologist to see where's the problem, or do you need to change therapies. It is a little bit complicated, but there are some risks with even any therapy in medicine that it may worsen certain conditions. And not that I'm saying that we shouldn't be using these. These are wonderful therapies for acromegaly, but we always got to keep in mind what we need to follow for. That's why we follow your diabetes, your A1C, and your glucose, and so on, okay? So this is just a nice graph showing that diabetes is actually it's actually quite common in patients with acromegaly. In fact, this needs assessment showed that in about a third of patients with acromegaly have diabetes. But what this slide doesn't show is that many, many patients have prediabetes in acromegaly, or we call it impaired glucose tolerance or dysglycemia. So sure, this is fine and dandy to have overt diabetes, or overt diabetes is like you definitely have the diagnosis, but many people might have borderline diabetes or prediabetes. Okay, so the key message is in patients with acromegaly, prediabetes and diabetes is very, very common. So it's like in acromegaly, it's a common cause of other diabetes. And unfortunately, it depends on who you're seeing. We're not doing a great job, and this is where we have to learn more and be more aggressive. We're not doing a really good job with many of the other comorbidities or the other conditions that are associated with acromegaly, in particular cholesterol management, high blood pressure management, and diabetes. Now, this is a little bit of an older study. I think we're getting better. And now this is looking at everyone who treats acromegaly, but we all know that people who do a lot of acromegaly probably do a better job of treating the conditions of acromegaly better and the acromegaly itself better. And it makes sense because I'll give you an example. If you get sent to a surgeon who's only doing spinal surgery, and you ask that surgeon, whether it's a female or a male, to remove your pituitary tumor, you're not going to get the same success as someone who does, for example, 2 or 3 pituitary surgeries a week, which is at least what we want. So you want to pick the person has an expert area in that condition, so you get the best outcomes. And there's some people who are really good at diabetes, and there's some people who are really good at osteoporosis, but you want to pick the best person who's seeing a lot of these conditions, so they actually manage the patients the best as can be. So that's why we try to create centers of excellence for whether it's acromegaly, whether it's Cushing's, whether it's certain cancers, and so on. So the message is you want to make sure you're treated by the person who has the most experience in general. So you want a center of excellence or an institution of excellence. And hopefully you'll get better control of not only acromegaly itself, but the conditions that are associated with acromegaly. So should everyone with diabetes, and I know this is a focus on diabetes and acromegaly, but should everyone with diabetes be screened for acromegaly? I think the simple answer to the question is no, because diabetes is so common. If you screened everyone, we would probably deplete the healthcare system, and then Trudeau definitely wouldn't get voted in again, right? So I think we have to be careful. We have to pick and choose wisely. That's a big term in medicine right now, choosing wisely, because there is a limited resource of funds that we have in our country, and we have to really, really be careful because we don't want to give, these tests are not 100% perfect either, right? The IGF-1 level, which is probably the best test for acromegaly, is not 100% perfect, and we don't want to make incorrect diagnosis because there can be subtle abnormalities, and you don't want to miss the diagnosis either, so we got to be careful. So treat people or screen for people who have a very high probability of having this condition. So who should we screen? Definitely if they have the typical features of acromegaly that probably Dr. Izat went into and Dr. Asa went into a bit. So I'm not going to go into that again. That's a definite, right? So someone who has several associated conditions with diabetes. So someone has unexplained osteoarthritis, especially of the hip, who has high blood pressure, for example, who has carpal tunnel syndrome, so a constellation of symptoms and signs that are associated with diabetes, then you should really think, maybe this is just not the garden variety type 2 diabetes mellitus. Maybe I should screen this patient for acromegaly. So we're looking for patterns, number 2. And number 3, if there's a large tumor suggestive of an adenoma in the pituitary, some of the guidelines recommend that you should probably screen for acromegaly, especially if they even have subtle features, because as it was probably mentioned earlier on, that acromegaly doesn't happen like this. It's not that one morning you wake up and you have acute onset of acromegaly. It's a very gradual condition. So, in fact, many of my colleagues, and even maybe you'll tell me, is that often it's missed the diagnosis, because if they see their family doctor, they don't notice the change because it's just happening so slowly. But you see someone new. In fact, I've seen a few cases referred to me by neurosurgery for just periodic management around their operation in the recovery room, and they really didn't think about the diagnosis. But we see these patients, wow. And when you talk to the patients, when you go back, there's been a journey. They've been complaining of aches and pains and numbness and tingling, and then you realize that, wow, this is acromegaly. So does everyone with a tumor in their pituitary area need to be screened? I would say probably not, but if there's any subtle features, if the size is relatively big, you should probably have a low threshold for screening. And again, there's no good evidence here nor there, and I'm sure if you take 100 endocrinologists, you're going to get 4,000 different answers. So that's humbling also, right? Okay. And I'll let Dr. Izzat and Dr. Imran comment on that later, what their approach is to the every cellular mass being screened for IGF-1 levels. So diabetes, I've already mentioned some of the complications. The simple way to think of it in terms of the long duration complications, think of big blood vessels and think of small blood vessels. Small blood vessels, I think of kidneys, eyes, nerves. The most common cause of blindness in Canada and the United States is diabetes. The most common cause of kidney damage in Canada is probably diabetes in association with high blood pressure. The most common cause of amputations is diabetes. So these are very, very common things with diabetes. And when you add on top of that acromegaly, it's like a combined worsening of, it's a bad combination. But the good news is we can treat a lot of this stuff. So the small blood vessels, it's the kidneys, eyes, and the nerves. The numbness, the tingling, the loss of sensation. These are very, very important things. But what about the big blood vessels? What's the killer? It's heart disease. So patients with diabetes have a 4 to 5 times increased risk of heart disease and death and high blood pressure when you have diabetes. So very, very important to screen for diabetes, because by controlling the glucose levels and the acromegaly and the associated risk factors, you can really decrease the complications associated with diabetes. So this is real, guys. So this is someone who had long-standing diabetes and had something called neuropathy, Ken, the nerve part. They couldn't feel anything. They were on a beach. The next thing they know, they stepped on a sharp rock, didn't feel anything, was fine. Next day, the patient had a fever and didn't know why. The spouse looked at the foot and saw this ulcer, and over the next few hours, the patient became very dizzy and ended up going to the hospital because the blood pressure was very, very low and became septic. Fortunately, the patient survived, but foot care in the setting of neuropathy is very, very important with diabetes. So the point I'm trying to make here is we need to prevent these complications. And the good news is in 2019, we can do a lot to prevent complications. Glucose control, avoiding smoking, good blood pressure control, and foot care is paramount in preventing foot ulcers. The patient luckily did not need an amputation because it was treated with antibiotics and good dressings and good wound care, and luckily this was a good outcome. So these are, does anyone know what this is? This is a very smart crowd. So this is a retinal photograph, okay? So this is showing some changes with the long-standing diabetes also. We call them dot hemorrhages. There's even some macular edema. These are medical terminologies. The bottom line is uncontrolled diabetes can have an effect on the eyes when you look into the eyes. The only place in the whole body where you can see arteries is the eye. We call it the window of opportunity, right? So this is a great place because nowhere else actually you can see arteries. It's just the eye. Again, we can prevent this also with good glucose control and regular eye screening and so on. So this is a patient with diabetes since a very young age. Does anyone know what this is? Or it's an artery, right? This patient was 9 years old. Okay? Obese, very strong family history of diabetes. And you can see this can start very early on. So this is not about people who are 40 or 50 anymore, right, guys? This is about young kids these days who are adopting a very sedentary lifestyle, who are not walking, who are eating lots of McDonald's and Harveys. The good stuff on the weekends fine sometimes, but I'm talking every day, right? Supersize stuff, right? Who saw the movie Supersize, right? So you can see this is happening in our own country. So again, we can prevent this, and we have to be really attentive to our children to make sure we prevent that. So I presented some stuff that happens with diabetes and acromegaly. So now I'm going to give some good news, okay? So what do? We're going to go to the ABCs. Okay, sugar is okay in moderation. Everything in life is okay in moderation. So get tested for diabetes if you're at risk, and we want to control that A1C. The goal for most people with diabetes, their A1C should be less than 7.0%. That's the goal. Ask your doctor for that test, okay? And if you have diabetes, ask for it also, because we have to self-empower ourselves too to make sure we can control our diabetes. What can we do? By doing this, we can reduce kidney damage, eye damage, and nerve damage, and maybe, depending on where you cap it, maybe heart damage, maybe. How do we do this? Healthy lifestyle and medication, and also in this setting, controlling your acromegaly also with the medications and the therapy available these days. I'd be happy to share my slides, okay, Deanna? I'll send them to you. You can share them with everyone. I have no problems at all. Okay, yeah, okay. Even my slides, I have no problem sharing them, okay? No problem at all. As long as you don't change things around and then I say something and it's nice to like, make sure you don't put brain biopsy for everyone with acromegaly or diabetes or something like that. So next is B. B for blood pressure. Very, very important with diabetes, okay? The goal for most of our patients with diabetes is less than 130/80, okay? Often people with diabetes need 2 to 3 drugs to make sure their blood pressure is okay. And this has the biggest effect on reducing stroke. Stroke is devastating, so blood pressure is mainly for stroke and also for kidney damage, eye damage, and heart damage. I encourage all my patients to actually get a blood pressure monitor, and I tell them to go to Costco, and I don't have any stocks in Costco, it's not my disclosure. The reason I tell them to go to Costco is if you go to the first aisle on the right in Lancaster, there's a big, huge shelf, $59.99. If you have a script, you can get sometimes insurance coverage. It's a Hypertension Canada approved device. And it actually works even on patients with atrial fibrillation, and it's quite accurate, and it includes a large cuff also. You don't have to go to Costco, it's just a joke. You can go to Shoppers or whatever, but it gives you some empowerment, okay? And helps you manage your own blood pressure and take in readings to your healthcare provider so you can optimize blood pressure control. And obviously controlling your acromegaly. I'm always going to put that in red because that's all part and parcel of it. But also what's important is other things too. Meditation can help sometimes, right? Lifestyle is important. Cutting back on your salt intake is important. Not drinking alcohol excessively. These are all risk factors for high blood pressure also. And there's a very nice site that I work very closely with, Hypertension Canada. This is a great site, hypertension.ca. It's free. We have a lot of free downloadable resources for the public and for the healthcare professionals. I encourage all of you to look at this site. It's very nicely made. We've spent lots of time. We meet together. We get a free meal. That's all we get, by the way. But we try to make a very nice website for our patients and for our healthcare providers so they can access this and empower themselves and improve their healthcare in general. What's C for? Smoking, cigarette. I have to put cigarette, okay? It could be for many things, but just to keep things in order. No one's ever wrong. So how much cigarette smoking is allowable? 0. 0, right? Actually, nowadays we can actually have cannabis. I did this slide, right? Cannabis could be there, right? But that's a whole different story. Oh, so how do I go? Okay. So smoking is the biggest bang for the buck. If you stop, you can reduce heart disease. And not only heart disease, cancer. There are so many cancers associated with smoking. I can go on and on. So if there's one thing you can do, is smoking. Easier said than done, but very important. And in fact, it's not only a life-saving thing, but it's a money-saving thing. I don't smoke. I think cigarettes are right now, how much, $6 a pack? Or I don't even know. 5? Okay. 5 a day. So most people who smoke, at least the patients that I see, they smoke a pack a day. So 3, that's like $2,000 a year almost, right? So think of what you can do with $2,000 a year. That's a lot of money. That's tax-free money, right? Right? T4 money, pre-T4